Priyadarshini, over to you.
Thank you, sir. Good morning, all, and wish you a happy new year ahead. Uh, so today's topic for discussion is carcinoma hypopharynx. We will be discussing the part one of this, as the answer told early stage hypopharyngeal cancer, the workup and management. So, coming to the hypopharyngeal cancer, giving a brief insight, all this data has been taken up from the fourth edition of Harrison's head and neck cancer and Scott Brown's eighth edition. So, the squamous cell carcinoma comprises of 95% of all the cancers in the hypopharynx and cervical esophagus. The mean age of patients who usually suffer from hypopharyngeal cancer is 65. Three-fourths of the patients are male, and 90% of them usually have a history of tobacco smoking. And alcohol has a higher neoplastic effect on hypopharynx than larynx. So, what are the other contributing factors to the development of this cancer is gastroesophageal reflux disorder, obesity, achalasia, Plummer-Vinson syndrome. Field cancerization is also a common phenomenon associated with this cancer. It has a worse overall survival because it presents in the advanced stage. Now, unlike the glottic cancer, which presents at an earlier stage, hypopharyngeal cancer usually presents at an advanced stage. Because of his anatomy, because of his lymphatic drainage and all. So it has a later stage of presentation. And 20 to 25% of hypopharyngeal cancer tumor specimens have associated HPV DNA. So HPV contributes to only 20 to 25% of this type of cancer. 70% of these patients, the major presenting feature is lymphadenopathy. So around 10 to 15% of the tumors present with synchronous tumors, and majority of hypopharyngeal cancer originate from the pyriform sinus. So hypopharynx, as we'll be discussing in the anatomy section, is divided into three subsites: the pyriform sinus, the posterior wall, and the postcricoid region. And among these, the majority of the hypopharyngeal cancer are usually originate from the pyriform sinus. And one-fourth of these are usually developed in the posterior pharyngeal wall, and 5% in the postcricoid region. And more than 75% of the patients, they present in the advanced stage, in the later stage, like stage 3, 4, and they subsequently go on to receive multimodality treatment. So this will be discussed later in the treatment section. Coming to epidemiology, hypopharyngeal cancers consists around 0.4% of all the cancers worldwide. It also forms 0.4% of all the cancer-related mortality. The incidence is highest in South Central Asia, followed by Central and Eastern Europe, Western Europe, and North America. Prognosis is usually detected by the stage of the tumor. Early stage disease, that is, have a 60% 5-year survival compared to the later stage, which present with multiple nodal spread. Coming to the anatomy, so hypopharynx extends superiorly from the hyoid bone above to the inferior border of cricoid cartilage inferiorly. So as we discussed, there are three anatomical subsites: bilateral pyriform sinus, posterior pharyngeal wall, and the postcricoid region. Coming to the anatomy of the pyriform sinus, these are actually bilateral conical structures. The open-ended base is superiorly at the level of pharyngoepiglottic fold, which is marked there, and the apex extends below the cricoid. So these are the pyriform sinus. They are conical structures. The posterior pharyngeal wall is usually composed of squamous mucosa overlying the middle and inferior pharyngeal constrictor muscles. These extend from the level of hyoid bone to the level of cricoid joint. And the postcricoid region usually composed of mucosa that overlies the cricoid cartilage, and part of the anterior wall of the laryngopharynx between the upper and lower border of cricoid cartilage is the postcricoid region. It is bound by the posterior arytenoid cartilages and the epiglottic folds superiorly and the cricopharyngeus muscles inferiorly. So this is the postcricoid region. Coming to the nerve supply, the inferior branch of the superior laryngeal nerve pierces the thyroid membrane and supplies the hypopharynx. The remaining sensation in the region is provided by the glossopharyngeal nerve. The recurrent laryngeal nerve provides motor function to the cricopharyngeus muscle and the posterior cricoarytenoid muscle of the larynx. Remaining primary motor supply to the hypopharynx is provided by the pharyngeal plexus. Coming to the local spread, lateral wall of the piriform sinus invades through the thyroid cartilage according to the anatomy. And if it involves the medial wall of the piriform sinus, it extends into the paraglottic space. And postcricoid tumors usually infiltrate the posterior cricoarytenoid muscle. So this is a fiber optic laryngoscopy done at our center in a patient presenting with subglobus sensation in the throat and difficulty in swallowing with a lymph node level 2 lymph node in the left side of the neck. So we did a FOL in this patient, and this is the finding of the FOL showing a left piriform sinus growth, which involves the aryepiglottic fold on the left side, partially obscuring the left true vocal cord, and there is restricted mobility on the left side of the hemilarynx. The right hemilarynx is mobile with the true vocal cord on the right side adequately visible. So this is a CT scan image of a patient reported to our center, and the CT scan shows an enhancing mass involving the left piriform fossa, and it measuring around 4 by 3 centimeters, extending to the left AE fold and the left half of the epiglottis, and involving the left paraglottic fat. Left false cord and two cords are displaced medially. Extralaryngeal spread is seen through the thyroid membrane and posterior to the thyroid cartilage.
Dr. Priyadarshini, sorry to interrupt. You may please use your cursor as a pointer to explain.
Yes, sir. Yes, sir. Yes, sir.
Okay.
Sure, sir. Yes, sir. So this is the lesion which is shown in the CT scan. It is showing enhancing lesion involving the left piriform fossa. So this area is the left piriform fossa area, measuring around 4 by 3 centimeters and extending to the left, involving the left aryepiglottic fold, left half of the epiglottis, and left paraglottic fat. Left false cord and true cords are also displaced medially, and it shows extralaryngeal spread through the thyroid membrane and posterior to the thyroid cartilage on the left. So this is another patient we saw in our center, and the CT scan reads as a large proliferative soft tissue lesion in the again on the left side of the PFS of the around size same as 4 by 3, and the lesion involves the walls of PFS and the AE fold. The lesion abuts the posterior pharyngeal wall in this section, and there is a large node that is present. It is a large nodal mass in the left level 2 of around 5 by 4 centimeter, and the lesion abuts the left carotid sheet and was compressing the IJV. So this is what I wanted to convey the nodal presentation, which is very common in a patient with hypopharyngeal cancer. So this is This is again another video, a fiber optic laryngeal endoscopy showing showing the left PFS growth with extension into supraglottis, the epiglottic fold region. So which presented to our center. This is also on the left side of another patient. This is the lesion which is extending to the supraglottis in this case. So coming to the presenting features of hypopharyngeal cancer, the throat dysfunction or global sensation may be the only presenting complaint in a very early stage, and there is referred otalgia, pain and bleeding. Hoarseness of voice may be the late presentation in piriform sinus and postcoid carcinoma. The examination findings which we usually observe in a patient presenting with hypopharyngeal cancer is a noticeable lump in the neck. Presence of external exolaryngeal spread is conveyed by widening of the thyroid cartilage, loss of laryngeal crepitus or the trotter sign, nodes in the neck, and there may be involvement of the skin and platysma. Tracheal displacement to be checked at the root of the neck, that is at the suprasternal spacer burns. The investigation that we usually order in a patient with this carcinoma is local examination we do under FOL, fiber optic laryngeal endoscopy, and sometimes order barium esophagogram, direct laryngeal endoscopy, and biopsy under general anesthesia is done to confirm. Contrast and CT scan, MR imaging to assess cartilage invasion, CT chest, thorax to rule out any lung mets, and PET CT for evaluation of primary disease and to exclude any occult distance metastasis, etc. Coming to the synoptic radiological treatment, what is the importance of radiology in the management of early hypopharyngeal cancer as such? That is, we assess the tumor volume, the locoregional extent of the disease, the pre-epiglottic and paraglottic space extension, exolaryngeal spread, thyroid and cricoid cartilage involvement, cricoid joint involvement of the visceral spaces like the prevertebral fossa, the carotid space, etc. And metastatic lymph nodes, usually to the level 2, 4, pretracheal and retropharyngeal group of lymph nodes. Usually the posterior pharyngeal wall cancers, they spread to the retropharyngeal lymph nodes, and piriform PFS and postcricoid, they spread to level 2 and 4. Factors which determine the treatment of hypopharyngeal cancer, so the biology of the disease, which we'll be discussing in the coming slides, the subsite that is affected, tumor and nodal factors, performance status of the patient, resources available, and the technical expertise of the institute. So what are the biological factors? Like squamous cell carcinoma, as we have discussed, they form the majority of the cancers, and they are more aggressive in the hypopharynx due to its rich vascular supply and lack of barriers to the spread of tumor. These tumors have substantial submucosal spread beyond the margin. The limits of the tumor seen up to 20 millimeter. It is usually proximal to the larynx, and the nodal disease that forms the majority of the presenting features and the performance status of the patient. The aim of the treatment is to achieve the highest degree of locoregional control with as little impact on the functional status, and to preserve phonation, swallowing, and respiratory function. So this is the aim of the treatment of hypopharyngeal cancers, to achieve the highest degree of locoregional control and to try and preserve the phonation, swallowing, and respiratory function if possible. So treatment of early stage, we will be discussing the TMH guidelines in the later stages. This is taken from the Harrison's standard textbook of head and neck cancer. According to it, the treatment of early stage is curative radiation therapy is preferred, and open and endoscopic surgery, that is partial laryngopharyngectomy with ipsilateral or bilateral neck dissection. Radiotherapy is usually preferred in the early stage because of the risk of chronic aspiration due to injury or sacrifice of superior laryngeal nerve that is involved when we go for surgery, and definitive radiation may allow patients to forego the toxicities associated with multiple treatment modalities. Early tumors of the lateral wall, that is partial pharyngectomy with lateral partial lateral thyroid cartilage, particularly the upper ala, we dissect off. Then the lesions of the medial wall of the sinus are potentially suitable for larynx sparing surgery in the form of partial laryngopharyngectomy. Coming to the TMH guidelines, the decision making for curative intent pyriform foci for stage 1 and 2, that is T1 to T2 N0 tumors, is external beam radiotherapy or transoral laser microsurgery. And the technical factors for transoral laser microsurgery is carbon dioxide laser is used with microspot with superpulse in continuous mode for 2 to 3 watts. And if we use if you go for radical radiotherapy, there is large field radiation primary with the neck, that is 66 to 70 gyri we give with 33 to 35 divided fractions for over a span of 6 to 7 weeks. Then post treatment, special attention is given to weight and nutrition management with nasogastric or PEG feeding to be maintained. And post organ preservation treatment evaluation involves direct laryngoscopy 6 weeks after treatment with PET CT scan if ordered to be done only after 12 weeks. Thyroid function test after 6 months or symptomatic, whichever is earlier. Swallowing therapy to initiate in pre-treatment setting and continue during and after radiation therapy. Coming to the decision making, same we are continuing with the TMH guidelines and decision making for curative intent post-cricoid and posterior pharyngeal wall cancers. We are discussing early stage tumors. So stage 1 and 2, we go for external beam radiotherapy and large field radiation primary with neck 66 to 70 gyri divided into 33 to 35 sections over a span of 6 to 7 weeks. Special attention same is paid to wet and nutrition with nasogastric or percutaneous gastrostomy tube feeding to be maintained. Direct laryngoscopy and CT scan 6 weeks after treatment. PET CT scan to be ordered only after 12 weeks. Thyroid function test after 6 months. Sorry for the typo error. Symptomatic, whichever is earlier. Swallowing therapy to be initiated and before treatment and to be continued during and after radiation. So there was a study, organ preserving transoral laser microsurgery for cancer of hypopharynx by Martinet et al. And the objective of the study was to assess the feasibility of transoral laser microsurgery in the treatment of hypopharyngeal cancer in 89 patients with special focus on pyriform sinus carcinomas and to report the oncologic and functional outcomes. And the conclusion was that in the study, the transoral laser microsurgery is a valid option to standard radical surgery or standard conservative treatment. Oncologic and functional results compare favorably while morbidity and complication rates tend to be lower. So this was a study. We'll be dealing with another study, that is management of early stage tumors with current therapeutic strategies for patients with early hypopharyngeal cancer. Will be that dealt with oncologic and functional outcomes. It was by Alexander Bozek et al. And various type of open surgical procedures were used in selected patients with T1 or T2 hypopharyngeal cancers. And among these classical surgical procedures, lateral hypopharyngectomy and supraglottic hemipharyngolaryngectomy with ipsilateral neck dissection provide satisfactory results. So this was the study, and it was analyzed in 87 patients who underwent supraglottic hemipharyngolaryngectomy for T1 or T2 cancers, and there were persistent swallowing problems with the 6 patients, and so the recovery of adequate swallowing function was much less certain than in supraglottic resections with frequent laryngeal penetrations or aspirations. And it was also concluded TORS is associated with a lower post-operative morbidity compared to open surgical procedures, including a lower rate of tracheostomies, faster recovery, swallowing function, and shorter hospital stay. GETEC reported a 12% rate of preventive tracheostomies, oral feeding recovery in 93% of patients, and medial hospital stay of 10 days. So, with organ preservation at the end of follow-up in TORS. So coming to the non-surgical management of early hypopharyngeal cancers, in addition to surgical management, radiation therapy alone is another validated option for patients with T1, T2, N0 early stage hypopharyngeal cancer. Nakamura et al. Reported a 5-year overall survival and disease-specific survival rates of 66 and 77.4% respectively for 95% they took up as study. And however, 65% are synchronous or metachronous cancers, and 10 of them died of a second primary cancer during the study period in non-surgical management of early hypopharyngeal cancer. So, coming to the conclusions of the study, the choice of appropriate therapeutic strategy depends on the tumor characteristics and extension of demarcated lesions, whether it is ulcerative, infiltrating, or exophytic tumors, the concomitant disease, especially the pulmonary function, performance status of the patient, with good general health and adequate respiratory function, who have an ulcerated and well-demarcated tumor suitable for transoral dissection, should preferably undergo primary transoral surgery with ipsilateral neck dissection. On the other hand, patient with a poorly demarcated tumor or severe comorbidity should be treated with definitive radiotherapy. The high risk of metachronous development of a second primary tumor is a strong argument for reserving radiation therapy for future treatment and therefore favoring a primary surgical strategy. So this was the conclusion of the study. Management of late stage tumors, as Sir said, it will be dealt in a separate class. So this was for just a brief insight. Management of post-cricoid tumors post-cricoid tumors are notorious because they are difficult to detect clinically until a later stage, present later than other hypopharyngeal cancer, and thus they require more extensive resection and reconstruction when adjuvant therapy. Because of extension into the posterior laryngeal tissues and surgical inaccuracy, patient will need laryngopharyngeal and perhaps additional partial pharyngectomy. So, treatment options for resectable hypopharyngeal cancer, and in various studies, the primary outcomes that were evaluated are overall survival, disease-free survival, any recurrence, locoregional recurrence, distal recurrence, and laryngectomy-free survival. The secondary outcomes were response rates following neoadjuvant therapy and comparison of treatment-related toxicity. The studies were evaluated for quality of evidence, including the grade, that is recommendation, assessment, development, and evaluation of risk ratios, rate ratios, hazard ratios were calculated with 95% confidence interval. So coming to the later part of treatment options for resectable hypopharyngeal cancers, induction chemotherapy followed by concurrent radiotherapy has no statistically significant features noted between the treatment arms of overall survival, disease-free survival, and laryngectomy-free survival. Pre-operative radiation therapy versus post-operative radiation therapy. In the overall survival was found to be better in post-operative radiation arm with a high risk of 2.44%, 95% confidence interval of 18.5. No statistical significant difference was noted in terms of treatment-related toxicity. We will be dealing with another study, that is the surgical treatment of hypopharyngeal cancer, a review of literature and proposal by Muir et al. And according to them, surgical resection is one of the standard therapeutic choices for hypopharyngeal cancer, whether or not combined with post-operative radiotherapy. The type of operation depends on the extension of the lesion and the subsite involved, and often requires some form of reconstruction. According to the study, the mean 5-year survival rate in patients treated with radiation therapy alone is estimated to be between 12.7 to 13.9%, and the survival rate among patients undergoing radical surgery followed by post-operative radiation therapy range from 25 to 60%. And for concurrent chemoradiotherapy, the 5-year survival was 30.7%. Surgical resection followed by radiation therapy, if necessary, had a higher disease-free survival rate compared to protocols and aimed at organ preservation chemotherapy. That is, the 5-year survival was 52% versus 42%. The TNM classification according to the latest AJCC 8 edition, that is, we all know the T1 is limited to one subsite of hypopharynx, greatest dimension less than 2 cm. T2 involves more than one subsite of hypopharynx or adjacent site and measures 2 to 4 cm in dimensions. T3 is more than 4 cm in greatest dimension or fixation of hemilarynx or extension to esophagus, and T4 moderately advanced or very advanced. 4A is moderately advanced local disease, invests thyroid, cricoid cartilage, hyoid bone, thyroid gland, esophagus or central compartment soft tissues. T4B is very advanced local disease, invests prevertebral fossa, encases carotid artery or involves mediastinal structures. So this was, as we discussed, the early stage, that is stage which we are discussing, the stage 1, that is the tumor is no more than 2 centimeter in diameter and it was N0 M0. T2 is between 2 to 4 centimeters and no progression to lymph nodes or other regions of the body. So that the later stage will be discussed later. DISA's classification based on the type of defect of pharyngoesophageal defect after total laryngectomy and the choice of suitable reconstruction method needs a special reference in our class for today. So this was proposed by DISA's et al. According to them, the defect and the possible reconstruction. Type 0, minimal defects of pharyngoesophageal segment that are amenable to primary closure. Type 1 is partial lesions affecting less than 50% of the pharyngoesophageal segment, and they can then type 2 is partial lesions affecting more than 50%. Type 3, extended longitudinal lesions involving other anatomical regions like nasopharynx, oropharynx, floor of the mouth or jaw. And type 4, that is pharyngoesophageal defect with extension to the cervical esophagus. Urken et al. Propose a new classification after DISA et al. And according to them, the type 0 is minimal defects of pharyngoesophageal segment that are amenable to primary closure. Type 1 is non-circumferential defect with the presence of a viable strip of mucosa. And type 2, circumferential defect extends no further cephalid than the level of vallicula. Type 3, circumferential or non-circumferential defect extending cephalid to the level of vallicula. And type 4 was any resection that extends caudal to the level of clavicles. So according to the study by Muir et al., the partial resection that is they did with hypopharyngeal lateral wall piriform sinus, it was direct closure in less than 50%, and they also used, where it was required, plactisma, radial free flap or ALT, and for hypopharyngeal posterior wall they use RFF and ALT. For circumferential resection, according to Urken classification, without mediastinal invasion, jejunum was used, RFF, ALT, and tunnel pectoralis major with stent ALT was used. With mediastinal invasion, it was a gastric pull-up. So coming to discussion that was concluded by Muir et al. In that study, when the surgery is not indicated, though we are dealing with early stage cancers and this should be reserved for the later stage, but still this needs a special mention here. If the tumor has invaded the entire piriform sinus, conservative and advanced lateral pharyngolaryngal tumor is visible in selected cases only. Pharyngolaryngal tumor limited to one wall with or without extension to the piriform sinus apex, and tumor must not cross the midline of the retrocricoid region. In these cases, surgery is not indicated. It must not extend cranially, infiltrating the interarytenoid mucous membrane. So these things will come up in the later classes when we deal with the latest management of later stage carcinoma. The integrity and amount of healthy vocal cord is very important for preservation of functional speech, and tumor extension into posterior hypopharyngeal wall need not be a contraindication to surgery as long as the lateral wall of the contralateral piriform sinus is not affected. And when the tumor affects the posterior wall of the hypopharynx without extension below the arytenoid plane and into the cervical esophagus, the choice of reconstruction has to consider the functional outcome in terms of swallowing. This was another study that dealt with hypopharynx reconstruction for primary hypopharyngeal carcinoma. So it was by Yuhang et al. It dealt with the primarily reconstruction. So the study aims to retrospectively evaluate disparate reconstructive choices in patients with primary hypopharyngeal carcinoma undergoing tumor dissection. Most of them were treated with following treat technique: gastric pull-up, pedicle pectoralis major myocutaneous flap, and radial forearm free flap. The focus was on the post-operative complication, morbidity, function of deglutition 1 month after hospital discharge, and the disease-free survival outcomes. The results were the 1 month after all surgery, 56 of 65%, that is 86.2% achieved solid or semi-solid normal swallowing functions for gastric pull-up patients, and 66.7% for RFF, and 60% for the pectoralis major flap respectively. And the post-operative complications occurred in 15, 18 and 16 respectively for gastric pull-up, radial free flap and pectoralis major respectively, including the complications included anastomotic necrosis, pharyngeal fistula, wound infection, pulmonary and cardiovascular complications. So the complications, post-operative complications rate were minimal for gastric pull-up patients. And that is the conclusion, that is gastric pull-up showed satisfactory outcomes for reconstructions with hypopharyngeal carcinoma requiring esophageal resection. So coming to the EOTC trial that should be dealt in this class, that is why I put up the slide. It compares sequential arm, that is induction chemotherapy followed by a 70 guided radiotherapy for the responders of a total laryngectomy and postoperative radiotherapy, and an alternating arm. After a median follow-up of 10.2 years, 10-year survival with functional larynx and overall survival was similar in both arms. GOTEC trial compared induction chemotherapy to induction chemotherapy that allowed the three chemotherapy agents, and the 10-year laryngopharyngectomy rates were were 70.3% versus 46.5% in TPF and PF, and 10-year laryngeal dysfunction-free survivals were 63.7 versus 27.2. However, the overall survival and disease-free survival were not statistically improved in both the arms. These data, along with those other randomized studies comparing the induction chemotherapy in these two arms with locally advanced or unresectable head and neck cancers, have confirmed the three-drug regimen as the gold standard induction chemotherapy approach in head and neck cancers. And the RTOG 9111 trial is an important study in laryngeal cancers with stage 3 and 4 glottic or supraglottic squamous cell carcinoma, assigned to induction chemotherapy followed by RT, concomitant chemoradiotherapy with cisplatin, and there was no significant difference in the 5-year laryngectomy-free survival between the patients treated with induction chemotherapy and those treated with concomitant chemotherapy, both being superior to radiotherapy alone. Overall survival also did not differ significantly, although there was a possibility of a worse outcome with concomitant relative to the induction chemotherapy. And so thank you, sir. This was my presentation for today.
Thank you. Dr. Priyadarshini, you have talked of gastric pull-up and many of the trials addressing actually the issue of advanced hypopharyngeal cancers.
Yes, sir.
The trials which you are showing are actually related to advanced hypopharyngeal cancer. I know you are a surgeon and a good surgeon and a head and neck oncologist. I think as a resident, you should know about the radiation techniques also, especially in early hypopharyngeal cancers. How do you plan your treatment in these situations? What is IMRT? What is IGRT? Which technique is required where? What facilities do you have in your center? I know you have top of the line, but I think we need to know the other specialties also, rather
Yes.
than focusing only on surgery. Open surgeries are being done less and less, and the TORS is actually coming in a big way in hypopharyngeal cancers also, T1, T2 lesions. And you have mentioned about TORS and TLM, but maybe some more detail of TORS in early laryngeal and hypopharyngeal cancers. I think over to Dr. Kapila.
Thank you, sir. Like you mentioned, yes, we should have had more detail on radiation and what was this, especially considering it's early hypopharyngeal cancer. Yeah, most of it is treated by radiation, and surgery is still a limited role. But I think the issue with trials, also the issue what we see is the number of cases which would actually present in an early stage and be amenable to say that this method is better than the other is very difficult. And most of these trials which we mentioned, uh, most of them included actually earlier stage, though the nodes were higher. So they ended up in a stage 3, stage 4, and ended up in all these trials. So it cuts both ways, but as of now, the evidence is still open whether TORS is better than our non-surgical approaches for hypopharyngeal cancer, considering the present robots which we have are not so.
I'm just talking of the open surgeries for early hypopharyngeal cancers.
Open
Uh,
surgeries are quite limited, sir. Very
yes,
limited. We
very
hardly ever
limited.
do it, but we need to know that yes, it was being done at a time. Yes, and
Yes.
though no one does it nowadays. Robotic, it's still a way off because a regular robot just doesn't reach the hypopharynx completely, and getting margins is very difficult with that. The newer robots, once we get the single port or probably the other newer other different robots, non Da Vinci, maybe give us a better approach to the hypopharynx, and maybe we may move back to a surgical approach for the early cancers. Till then, I think a non-surgical approach being radiation and CTRT would be the best.
So,
Anything else, sir?
I think we can see the chat box.
I don't see any major questions in this. No, sir.
Everybody is in a New Year mode. Dr. Priyadarshini, you have presented it so well. Huh? There are no questions.
Sorry, sir, for not incorporating the techniques of
No, no,
radiotherapy
it's
as I was
all right, all
expecting
right,
That's
to.
all right.
okay. That's okay. That's okay.
That's
That's not.
okay. That's not an issue.
So
So,
thank you, sir, for
what
guiding
about
for
your
me this that I should be more focused on the IMRT, IGRT, and all those things I should know.
We need
because
to
the
know.
And
topic is early
yes, sir. Yes,
and
sir.
मैं यही कहता हूं सभी को कि सबसे पहले अच्छे ऑन्कोलॉजिस्ट बनो सर्जन तो बन जाओगे बट सबसे पहले ऑन्कोलॉजिस्ट बनो
Yes, sir. Very
ठीक है
true, sir. Sir, I should have taken help from my radiation oncology colleagues in this matter, sir. That I should definitely take keep in mind for my further presentations and classes and
in your
academics.
lifetime you have to think what is best for patient
Yes,
not
sir.
that I'm a surgeon I will do surgery that's not the I'm
Yes.
sure you are sending cases religiously to the radiation oncology colleagues and medical oncology colleagues also. Dr. Kapila, any addition? Then we can close if there are no questions.
There's just one question that was asked on the chat box. Stage 2, or if greater than stage 2 subside, can we still go for TORS? I would say no, because stage 2 also, it entirely depends on whether you can get an adequate margin. So imaging as well as endoscopy is very important. And if that you can get an adequate margin with TOS, then TOS definitely you can consider, but it has to be a very, very planned thing. You cannot just say, just because I see uh, I mean, everything is like, what do you say that?
I think your voice is breaking. Some
Oh, sorry. I think I'll type it. It'll be easier. So the main point is if we should be able to get adequate margins. If we can't get
yes.
adequate margins, TOS should not be attempted. That is the most important.
Okay, I agree with you. Navneet ji,
Excellent, sir. So if there are no more questions, thank you very much, trainees and faculty members, for joining the